Bismillahirrahmanirrahim. So today's lecture is about pleural effusion. It's the accumulation of fluid within the pleural space is termed as pleural effusion. The accumulation of frank pus is termed as empyema. That of blood is hemothorax, and that of chyle is chylothorax. In general, pleural fluid accumulates as a result of either increased hydrostatic pressure or decreased osmotic pressure, transudative effusion as seen in cardiac, liver, or renal failure, or from increased microvascular pressure due to disease of pleura or injury in the adjacent lung. Exudative effusion causes of majority of pleural effusion are identified by a thorough history examination and relevant investigations. Clinical assessment symptoms pain on inspiration and coughing and sign of pleurisy often precede the development of an effusion, especially in patients with underlying pneumonia, pulmonary infarction, or connective tissue disease. When breathlessness is the only symptom, however, the onset may be insidious depending upon the size and rate of accumulation. So main causes of pleural effusion in tuberculosis, it's amber colored, it's exudative and lymphocytic, and its spotting feature which can help in the diagnosis includes the positive tuberculin skin test and isolation of mycobacteria tuberculosis in the pleural fluid. Its incidence is quite low, its sensitivity about 20% only, and pleural biopsy and high yield it's about 80%, which helpful for diagnosis of tuberculosis, yeah, tuberculous pleural effusion, and raised ADA level in the pleural fluid are also supporting in the diagnosis of tuberculosis. In malignant pleural effusion, it's usually blood stained, it's exudative mostly, can be transudative, and it's making serosal cells or lymphocyte or clumps of malignant cells. Pleural biopsy is quite has high yield in it. Evidence of malignancy anywhere else in the body can be supportive. Cardiac failure, fusion due to heart failure is usually serous, straw colored, is transudative, and other signs of cardiac failure are found on examination and it responds to diuretics. In pulmonary infarction, the fluid is blood stained, it's usually exudative, and sometimes it can be transudative. Red blood cells, eosinophilia is found. Evidence of pulmonary infarction on CT. Obvious source of embolism like from the legs on Doppler ultrasound of the legs. Factor predisposing to the venous thrombosis should be asked. In rheumatoid, serous turbid if chronic exudative lymphocytic organic polymorphs, rheumatoid arthritis factor can be found, anti-CCP antibodies can be done, and tadpole cells are found in the effusion. Cholesterol is sometimes high in the effusion, and glucose is typically very low, below the 60. In SLE, the effusion is exudative and antinuclear ANA can be found, and anti-double-stranded DNA is usually raised. In acute pancreatitis, again, it can be serous or blood stained, it's exudative, and higher amylase is found in the pleural fluid than in the serum. So, what are the investigations? These include the X-ray. The classical appearance of pleural fluid on an erect PF chest film is a curved shadow at the lung base, blunting the costophrenic angle and ascending towards the axillum. The fluid appears to track up the lateral chest wall. In fact, fluid surrounds the whole lung at this level, but casts a radiological shadow only where the X-ray beam passes tangentially across the fluid against the lateral chest wall. Around 200 ml of fluid is required in order for it to be detectable on an PA view of the X-ray. Previous scarring adhesions in the pleural space can cause localized effusion. Pleural fluid localized below the lower lobe subpulmonary effusion stimulates as an elevated higher diaphragm. Pleural fluid localized within an oblique fissure may produce a rounded opacity that may be mistaken for a tumor. Ultrasound is more accurate than plain X-ray just for determining the presence of fluid in the pleural space. A clear hypoechoic space is consistent with the transudative, and the presence of moving floating density suggests an exudate. The presence of septation most likely indicates an involving empyema or dissolving hemothorax. CT scanning is indicated where malignant disease is suspected. So this is the light criteria which helps to differentiate between transudative and exudative effusion. It has three parts. Exudative is likely one or more of the following criteria are met. Pleural fluid protein to serum protein ratio greater than 0.5, pleural fluid LDH to serum LDH ratio greater than 0.6, or LDH greater than two-thirds of the serum LDH. Pleural aspiration and biopsy. In some conditions, it should not be necessary to sample fluid unless atypical features are present. Appropriate treatment should be administered and effusion re-evaluated. In most other circumstances, however, diagnostic sampling is required. Simple aspiration provides information on the color and texture of the fluid, and these alone may immediately suggest an empyema or coiled thorax. The presence of blood is consistent with pulmonary infarction or malignancy but may result from traumatic TAB. Biochemical analysis allows classification into transudative and exudate, and gram stain may suggest parapneumonic effusion. The predominantly cell type provides useful information, and cytological examination is essential. A low pH suggests infection, but may also be seen in rheumatoid arthritis, ruptured esophagus, advanced malignancy. Ultrasound or CT-guided pleural biopsy provide tissue for pathological and microbiological analysis. Where necessary, video-assisted thoracoscopy allows visualization of pleura and direct guidance of a biopsy. So, management depends on underlying cause. Like in heart failure, we give the diuretics. In infection, we have to give the antibiotics. Therapeutic aspiration may be required to palliate breathlessness, but removing more than 1.5 liter at a time is associated with a small risk of re-expansion pulmonary edema. Effusion should never be drained or dryness before establishing a diagnosis, as biopsy may preclude until further fluid accumulates. Treatment of underlying cause like heart failure, pneumonia, pulmonary embolism, or subphrenic abscess will often be followed by resolution of the effusion. The management of pleural effusion is pneumonia, tuberculosis, malignancy is that below. So, empyema. Empyema is a collection of pus in the pleural space which may be as thin as serous or thick that is impossible to aspirate even though a wide bore needle. Microscopically, neutrophil leukocytes are present in large number, and empyema may involve the whole pleural space or only part of it, and is usually unilateral. It is always secondary to infection in a neighboring structure, usually the lung, most commonly due to the bacterial pneumonias and tuberculosis. Over 40% of the patients with community-acquired pneumonia develop an associated pleural effusion, and about 15% of these become secondly infected. Other causes are infection of a hemothorax following trauma, surgery, esophageal rupture, and rupture of subphrenic abscess through the diaphragm. Both pleural surfaces are covered with thick, shaggy inflammatory exudate. The pus in the pleural space is often under considerable pressure, and if the condition is not adequately treated, pus may rupture into a bronchus, causing bronchopleural fistula, a pneumothorax, or tract through the chest wall with the formation of a subcutaneous abscess or sinus, are so-called empyema necessitans. Empyema should be suspected in patients with pulmonary infection if there is severe pleuritic chest pain or persisting or recurrent pyrexia despite appropriate antibiotic treatment. In other cases, the primary infection may be so mild that it passes unrecognized, and the first definite clinical features are due to the empyema itself. Once an empyema has developed, systemic features are prominent. Systemic feature includes fever, rigors, malaise, weight loss, polymorphonuclear leukocytosis, high CRP levels. Local features include pleural pain, breathlessness, cough, sputum, usually because of underlying lung disease, copious purulent sputum if empyema ruptures into the bronchus, clinical signs of pleural effusion. X-ray appearance may be indistinguishable from those of pleural effusion, although pleural adhesions may confine the empyema to a D-shaped shadow against the inside of chest wall. When air is present, as well as a pus pneumothorax, a horizontal fluid level mark the air liquid. Ultrasound shows the position of fluid, the extent of pleural thickening, and whether fluid is in a single collection or multi-loculated containing fibrin and debris. CT provides information on the pleural underlying lung parenchyma and patency of the major bronchi. Ultrasound CT is used to identify the optimal site for aspiration, which is best performed during a wide bore needle. If the fluid is thick and turbid, empyema is confirmed. Other features suggesting empyema are fluid glucose of less than 3.3, LDH greater than 1000, and pH less than 7. However, pH measurement should be avoided if the pus is thick as it damages blood gas machine. The pus is frequently sterile on culture if antibiotics have already been given. The distinction between tuberculous and non-tuberculous disease can be difficult, may require pleural biopsy, histology, culture, or nucleic acid amplification tests. Management. An empyema will heal only if infection is eradicated and the empyema space is obliterated, allowing apposition of the visceral and parietal pleural layers. This can only occur if re-expansion of the compressed lung is secured at an early stage by removal of all the pus from the pleural space. When the pus is sufficiently thin, this is most easily achieved by insertion of a wide-bore intercostal tube into most dependent part of the empyema space. If the initial aspirate reveals turbid fluid or frank pus, or if loculations are seen on ultrasound, the tube should be put on suction and flushed regularly with 20 ml of normal saline. If the organism causing the empyema can be identified, the appropriate antibiotic should be given for 2 to 4 weeks. Empirical antibiotic treatment, intravenous comoxiclav, cefuroxime, and metronidazole should be used if the organism is unknown. Intrapleural fibrinolytic therapy is of no benefit. An empyema can often be aborted if these measures are started and if the intercostal tube is not providing adequate drainage. Surgical intervention is required to clear the empyema cavity of pus and break down any adhesions. Surgical decortication of the lungs may also be required if gross thickening of visceral pleura is preventing re-expansion of the lung. Surgery is also necessary if the bronchopleural fistula develops. Despite the widespread availability of antibiotics that are effective against pneumonia, empyema remains a significant cause of morbidity and mortality. Thank you so much.